Dr. James L. Januzzi joins us from Massachusetts General Hospital. Dr. Januzzi has contributed greatly to the understanding of cardiac biomarker testing in patients with heart failure, where his work with the natriuretic peptides has set international standards for their use in diagnosis, prognosis, and management of patients suffering from both acutely decompensated heart failure and chronic heart failure. Dr. Januzzi's research group recently completed a study demonstrating the value of NT-proBNP testing to more optimally manage patients with heart failure. The pro-BNP outpatient tailored chronic heart failure therapy, or PROTECT study. His topic today is biomarker-guided heart failure management. So please help us welcome to our stage Dr. James Januzzi. Thanks for being here today.
Thank you very much.
Appreciate
It's a pleasure to be here, folks, and happy to be speaking today. I looked at the curriculum that's going to be shown today, and it's a really nice list of talks, so it's nice to be up here. And this is an exciting area for those of us who've been working with biomarkers for the last 15, 20 years, because it's really illustrative of the place where we all sort of feel markers need to evolve. There was a time when biomarkers were a curiosity. They helped us make the diagnosis of myocardial infarction, certainly, for example, with troponins. And then they evolved into something that was nice to have in certain circumstances to help make the diagnosis of heart failure. But then something interesting happened about 10 years ago, which is that we realized that markers like the natriuretic peptides were useful for establishing prognosis in heart failure. And from there comes the necessary question of asking, can we use them to better manage patients? And that's really where we're looking these days. So my disclosures are here. Very important to recognize I do research for a number of biomarker firms. So why markers? For that matter, why implantable hemodynamic monitors or some other tool to improve the care of patients with heart failure? So this is predicated on the observation that despite the fact that we have excellent therapies for heart failure, those affected by the diagnosis suffer considerable morbidity and mortality. The standard management, if I see a patient in the office with heart failure, includes evaluation of the patients and making their therapies adjusted based upon their symptoms, their signs, and their overall risk profile. And that's in the guidelines. Very importantly, the goals of our care in heart failure is to achieve what is referred to as a guideline-derived medical therapy program, or GDMT. You'll see a lot of that in the next iteration of the guidelines. So, clearly our orders are set. We need to be excellent clinicians for our patients and maximize their medical therapy based on their symptoms, signs, and risk. And although that approach is standard and adopted by the American College of Cardiology, the Heart Failure Society of America, etc., the reality is that titration of therapies goes suboptimal in the real world. And we can debate about whether that's good, bad, right, wrong, but the reality is that that is unfortunately the case, with the highest risk patients frequently being the patients with the greatest opportunities for addition and up-titration of therapies. And so it's not just that our therapies are less adequately deployed, it may be also that the patients who benefit the most are not getting those therapies. Now, part of this may have to do with limitations in our ability to recognize when a patient merits such therapies. So it may not be that the clinicians are just, not paying attention. It may be that we're not able to best identify those patients with an inadequate program. But whatever the case may be, this is a real issue. And this has therefore led to this concept of identifying tools, objective measures to assess risk and guide heart failure therapy. And that's where biomarkers have really come into play. So this is Adolfo Debold. He's an Argentinian currently living in Ottawa. And many years ago, Professor Debold, who won the Nobel Prize for his work, identified these electron-dense granules in homogenates of atrial tissue isolated from rat hearts. Subsequently, re-injection of these homogenates into other animals induced an intense natriuresis. And so he referred to these substances found in the atrial tissue as atrial natriuretic factor. ANF was subsequently identified as a peptide found in many tissues in the body, related to multiple different peptides in the body that led to the similar vasodilation, natriuresis, and diuresis that we see from them. And so this family of natriuretic peptides was born. It turns out there are multiple natriuretic peptides. We have focused largely on B-type natriuretic peptides because up until recently, the analytical methods for measuring ANP remain somewhat less reliable, although there is now a pro-peptide assay for ANP that can be measured with great accuracy. So now we can measure ANP as well as the B types. And I'll remind you, at least when we talk about B-type natriuretic peptide, there's been a lot of work to show that while in the beginning when we started measuring BNP and NT-proBNP, we focused on their link to left ventricular size and function, we now recognize that multiple aspects of cardiovascular normative function as well as pathophysiology are associated with levels of natriuretic peptides. Put another way, they don't just reflect disease of the left ventricle, they reflect disease wherever there's myocardium. So right ventricular syndromes, atrial syndrome, so atrial fibrillation as an example, valvular heart disease, pulmonary pressures, ischemic heart disease, these all have an independent influence on concentrations of natriuretic peptides in patients with heart failure. And this is important because when we look at the therapies for heart failure that have effects on patients with heart failure to reduce their risk, these very same agents, diuretics, ACE inhibitors, other vasodilators, beta blockers, aldosterone antagonists, cardiac resynchronization therapy, etc., all tend to reduce natriuretic peptides in parallel with their benefits. So if you add a mineralocorticoid inhibitor, for example, to patients with heart failure, their BNP tends to fall. And if it does not fall, these patients do not accrue the benefits from the mineralocorticoid inhibitor. So it's this circular relationship between the biology of heart failure, the risk predicted by concentrations of natriuretic peptides, and response to therapy that has generated this concept of utilizing biomarkers as an objective guide to heart failure management. We know in acute heart failure that better, more secure diagnosis and better triage for the higher risk patients is one of the strengths of the natriuretic peptides. In other words, if you have a patient that's at high risk for adverse outcome presenting with acutely decompensated failure and you utilize a natriuretic peptide, you are more likely to make the diagnosis correctly and more likely to recognize the risk and treat them accordingly. And so, you know, retrospective as well as prospective analyses have proven that just the knowledge of a natriuretic peptide has a significant benefit in terms of outcomes on patients. But again, as I made mention of in my introduction, what we're really talking about is utilizing these markers as a barometer for identifying risk and then acting as a guide for therapy. In acute heart failure, it's well recognized that changes in natriuretic peptide concentrations from admission to discharge predict risk quite robustly. In other words, while the initial natriuretic peptide value upon admission to the hospital identifies high risk, if you look at the discharge achieved natriuretic peptide value at the time of discharge, that is an even more potent predictor of adverse outcome with this sort of curvilinear association associated with each increase in natriuretic peptide concentration. One question that's been asked is whether we should be aiming for a relative change during hospitalization. There's been talk about this 30% reduction from baseline to discharge, or is it a hard target? Should we be aiming for lower and lower values? And the answer is both are independently important. I would say that in the absence of prospective randomized trials, which unfortunately are lacking in this area, the take-home message for clinicians as they manage their patients in acute heart failure is that a baseline value is useful for diagnosis, prognosis, and establishing severity of heart failure. And then a pre-discharge value helps to identify that a patient has had a reduction and that lower concentrations are more associated with better outcomes, whereas patients who have rising or persistently elevated values have a higher risk. And so patients in black, red may be put into a telemonitoring program, closer follow-up with an early follow-up in the office, whereas patients in blue who've had a robust reduction and achieve very low values have a lower risk for recurrent heart failure events. So what can we say about acute heart failure? Well, at present, in the absence of randomized prospective studies comparing strategies between standard management and biomarker-guided care, we can say that trends in natriuretic peptides are strongly associated with improved outcomes if you can reduce them at the time of acute heart failure. This is ripe, however, for prospective randomized testing. So at the Mass General Hospital, for example, we actually operationalize this because, as you all recognize, 30-day rehospitalization is a big deal right now in heart failure. So at the end of heart failure hospitalization, if a patient has a rising NT-proBNP value, we actually intensify their therapy. In the absence of prospective data, this seems to be a logical and sound approach. On the other hand, in outpatient data, there's considerably more information about the use of natriuretic peptides to guide therapy. We know that they are prognostically meaningful across many different patient subtypes in heart failure, whether it's systolic heart failure or heart failure with preserved EF, and that absolute concentrations of natriuretic peptides predict substantial risk for mortality and heart failure hospitalization. But if you start measuring serially, and I think there is little debate at this point that serial measures inform more information than a single measurement, you start to learn more about your patients compared to if you just had a baseline value. So these are results from the VALHEFT analysis of patients with heart failure due to left ventricular systolic dysfunction, looking at their natriuretic peptide values at baseline and then again at 4 months. And in the VALHEFT study, patients were followed over time for mortality and heart failure hospitalization, and then looked at as a function of their trends of natriuretic peptide over time. And some interesting developments were seen. Patients who were low over time had best outcomes, and that's not that surprising. Patients that were elevated the entire time had the worst outcomes. Again, not that surprising. But there were changes in the middle groups here. We refer to these patients as lane changers. They've changed lanes from a low-risk picture up to a higher risk picture going above this threshold value, whereas some patients started out as high risk and fell over time. And as you would expect, changes in natriuretic peptide concentrations cause them to essentially switch their risk categories, such that by the end of the 4-month follow-up period, although those patients started out higher, their heart failure hospitalization and death rate was actually similar to patients who started out low. So if you have therapies that can lower natriuretic peptides over time, the question remained whether managing patients with the goal to suppress their NT-proBNP would be associated with better outcomes. And, you know, it's not sufficient at this point now to have a biomarker that says that, you know, ma'am, I'm really excited to tell you that this biomarker gives me some neat prognostic information. Isn't it interesting? You know, and the patient's sort of saying, you know, well, why does this matter? I mean, what they want to know is, can their doctor do a better job with an objective tool that helps guide heart failure management, identifying an inadequate medical program? Again, it's hard to really debate at this point that gaps in care exist. They do. These are data from the improved CHF cohort looking at surveys of practices nationwide, looking at adherence to evidence-based medicine and adherence to the goal of achieving that guideline-derived medical therapy goal. Gaps in therapy exist. Now, the good news is that with prompting, in this case in IMPROVE-HF, it was a questionnaire. It was a placard that was put in everyone's office, reminding them of the goals of care. You can see substantial improvements in multiple metrics of heart failure care. So yes, indeed, the gaps exist, and yes, indeed, they can be closed. In addition, just thinking again back to the fact that the biggest benefits from heart failure therapy are expected to be accrued in the highest risk patients, having a biomarker that not only identifies that therapy is inadequate, but also identifies risk would be expected to focus that care in the highest risk patients. But putting aside this controversial idea of utilizing a marker to cue guideline-derived medical therapy, I would argue that, you know, imagine yourself in the office seeing a patient that's on that guideline-derived medical therapy who has a rising natriuretic peptide value. Ignoring that rising value is putting yourself at risk of seeing a patient land in the hospital. And so to allow us to reactively respond to a changing risk is something that I find to be of great value when I monitor my patients in the office, with the idea that adjustments in therapy might be able to head off that impending complication. And then lastly, I'll show you some data about the fact that we believe that utilizing a biological measure that reflects underlying myocardial biology, as I showed you that big list of different things that biomarkers can reflect, by manipulating therapies to suppress these values, you can actually address, for example, ventricular remodeling in a more direct way. So how do we do this in the office? Well, standard evaluation and management, and again, up front, we have to be good clinicians for our patients. So we adjust our therapies to do our best to achieve that guideline-derived medical program. But then we measure natriuretic peptides. And if, in fact, the natriuretic peptides are above a goal threshold, for BNP it's around 100, 125. For NT-proBNP it's around 1,000. If patients are above that threshold of risk, patients should be reviewed for adherence to their medical therapies and lifestyle and dietary goals. It seems to me that my text always seems to be right on the cracks in the screen. And then we look at the medical program to identify potential opportunities for improvement in care. And trust me, they exist. Even in our practice, we can always find opportunities to up-titrate. And then when the therapy titration is done, we bring the patient back and we do it again. And we remeasure and we re-titrate. So there have been some trials that are positive. There have been some trials that are negative. And there have been some good lessons learned based on both the positives and negative trials of this approach. There is a pooled analysis that's about to be submitted for publication that Richard Troughton, who really deserves a lot of credit for first publishing this concept in the year 2000 in The Lancet. Richard has an analysis where he's taken all of the available trials that have been published in this space and pooled them together. And in this analysis, looking at mortality and heart failure hospitalization, there's a substantial reduction in the risk for both outcomes, including a reduction in mortality associated with natriuretic peptide guided heart failure management. So no heterogeneity, pulling them together increases power to give this kind of a result. So clearly an idea in need of large pivotal trials to prospectively validate them. So what have we learned from the negative and positive trials? Well, guided therapy appears to be more effective, generally speaking, in younger patients, and particularly in those patients with heart failure due to left ventricular systolic dysfunction. For the clinicians in the room, I could ask, how many know how to take care of heart failure with preserved EF? I mean, I tend to find that it's very much individualized at the patient level. If it's due to atrial fibrillation, you treat for atrial fibrillation, for example. So if the natriuretic peptide is high in this patient, you want to target the cause of the heart failure. And so an ACE inhibitor, for example, is not going to treat HFpEF. An ARB is not going to treat HFpEF necessarily. Beta blockers don't seem to have as much of an effect. And so, it's not surprising that LV systolic dysfunction is more responsive to this approach because we have a defined treatment strategy for these patients. Importantly, when we use guided therapy, the target natriuretic peptide value is critically important. Trials that have failed generally looked at a higher target value, so the values have to be low. Therapy has to be changed to achieve that natriuretic peptide value, and the lower you get, the better, and it takes time. Do not assume that a patient has a dry natriuretic peptide value just because after 1 or 2 visits you've gotten their NT-proBNP to 3,000 and that's as good as you're going to get. It can take time and titration and retitration in their meds, but it is possible to achieve these low values that improve care. So I'm going to give you some examples from our trial, the PROTECT study that you heard during our introduction, because it sort of sets the stage for the large prospective trials that we're about to be launching examining this approach. So in the PROTECT study, we enrolled patients with heart failure due to left ventricular systolic dysfunction with a median concentration of NT-proBNP just over 2,000, so a fairly representative heart failure population. And at follow-up, after a mean of 10 months of follow-up, we had reduced their natriuretic peptide concentrations by nearly 50%. But this was entirely driven by reductions in the NT-proBNP arm. In other words, in an unblinded fashion, guided by the natriuretic peptide, we were able to reduce concentrations by 50%, more or less. The standard of care arm, despite the fact that there was substantial uptitration in heart failure therapies in the standard of care managed patients, there was no significant reduction over time. And this has been seen repeatedly. If you don't measure the natriuretic peptide, in many cases, irrespective of good, uptitration and excellent adherence to medical therapies, frequently you don't see much change. It requires specific concerted effort to reduce the values in some cases. When you look at the outcomes of patients, it's not surprising given the fact that in blue, patients had lower natriuretic peptide values. Their total cardiovascular event rate was reduced substantially by guided therapy for heart failure management. And if you look at time to first event, it's not just total cardiovascular events. It's not that it was being driven by a few patients that were recidivistic and kept having events. Just looking at time to first event, there was a substantial reduction associated with NT-proBNP guided care that showed up at about 2 months after initiation of heart failure management, guided by natriuretic peptide values. You can look at the number needed to treat in drug trials. If you look at the number needed to guide, if you will, in PROTECT, to prevent one heart failure hospitalization, we had to guide 2 patients. So it was a substantial effect on adverse outcome, so much so that the trial was suspended at interim because of the degree of reduction in adverse events. Some of the nicer aspects about PROTECT, given that it was a single center study, we were able to look at a number of metrics that are somewhat underappreciated in heart failure trials. One is quality of life, and we examined the effects of guided therapy in yellow versus standard of care therapy in red on patient-reported quality of life from baseline to the end of the trial. And you can see that while quality of life improved in both arms of the study during the course of the trial, in the standard of care arm, there was a wearing off effect over time, such that by the end of the study, the quality of life was actually significantly better in the NT-proBNP guided arm. So while these patients were brought back to the office more frequently to achieve their heart failure therapeutic goals and to suppress their natriuretic peptide value, it was well tolerated with no significant treatment-related adverse events, and quality of life actually improved. So that's a very reassuring thing as we start thinking about newer ways to manage patients with heart failure. We want to see not only improved outcomes, cost effectiveness, but also improvements in terms of the patient-reported quality of life. Now, remember when I said in that slide about general take-home messages from the guided therapy trials that younger patients tended to respond better? In PROTECT, we actually found, somewhat to our surprise, that older patients, who are supposed to be the patients who do not respond to guided therapy, actually got not only preserved benefit from guided therapy, but actually more robust reduction in adverse events compared to younger patients. So much so that the older patients drove the primary outcome of the study. So we differ from other clinical trials that have looked at this question, but I'll remind you that it's not the biomarker. It's what the clinician does with the results of the biomarker that tells you whether an approach is going to work. It's different than giving a drug versus a placebo. The difference between, say, a placebo-controlled trial and guided therapy is if the biomarker is elevated and the clinician isn't really successful in reducing it, the patient's not going to improve. We actually looked at the patients in the over 75 population in PROTECT and found that we managed them very differently than the younger patients. We brought them back more frequently. We made more gradual up-titrations of their medications. Really, it's real world, right? For the clinicians in the room here, that's what you do in real world, medicine. And in clinical trials, frequently, younger patients and older patients are treated exactly the same, and you just can't do that with this approach. So we think that the way that we approach patients in PROTECT, taking elderly patients a little more gradually with a little more gradual up-titration, explains the fact that we were successful in not only reducing their natriuretic peptide values, but cutting their adverse event rates substantially. Now, coming back to this piece about heart failure biology, again, whether you talk about biomarkers of necrosis, biomarkers of remodeling, like galectin-3 or ST2 or GDF-15, or the natriuretic peptides, you want to keep an open mind. They are not just reflective of one process in the heart usually, and the natriuretic peptides are very much like that, which is to say that they reflect a wide array of abnormalities in cardiac structure and function. Thus, if you have two populations of patients in whom one has substantial improvement in their NT-proBNP and one does not, it should surprise no one that when you look at various cardiovascular measures like change in ejection fraction, change in LV volumes, diastology, as well as right ventricular pressures or function, that substantial reductions in natriuretic peptide concentrations in blue, these are the patients guided with unblinded measurements, had more significant improvements in all of these metrics of cardiac structure and function compared to those patients managed with standard of care management in red. Now, again, in the clinical trial world, patients typically get better in both arms. The concept of all boats float equally when you're seen in a clinical trial, and yes, EF improved in the standard of care patients, LV volumes got better in the standard of care patients, diastology got better, etc. It's just that the NT-proBNP guided patients got more better right? So remodeling improves, diastology improves, right ventricular size and function improves. So an important observation. Bringing it to a conclusion in the next couple of slides, we've looked at some of the nuances from PROTECT and from other clinical trials, including the battle-scarred study, which was one of the larger trials done in Christchurch, New Zealand. And we asked the question, of despite best efforts, what happens if you can't get to the patient to the goal of 1,000 picograms per ml? In other words, if you really know you've done as good as you can do and the patient isn't dropping, what happens to that patient? What if a patient has a rising value? What does that mean? Remember that whole point about reacting to a change in risk, it's, as one of the values of natriuretic peptides? And what about time and response? For those people that are, intimately associated with anticoagulation research, therapeutic time and response, TTR, is something that we think a lot about with international normalized ratio for atrial fib. The longer a patient has an INR of 2 to 3, the better their outcome is if compared to if they are above or below. So can we use this concept of time and response relative to natriuretic peptide concentrations? Well, the first point is, achieved natriuretic peptide concentrations strongly predict risk. So if your patient is as good as they're going to be and they fall, 2 to 3,000 or 3,000, 4,000, their risk is high. And so if you've really done as good as you can do, and they still remain quite elevated, that tells you that something is coming in this patient's near future, and it is, in theory, logical to start thinking about what your response is going to be, whether it's left ventricular assist device implantation, referral for listing for transplantation, invasive hemodynamic monitoring, more direct invasive evaluation like an outpatient right heart cath to reassess. It's important to recognize at this point in 2012, we know that the achieved natriuretic peptide value independently predicts adverse outcome. If a patient is treated with guided therapy and they respond in the dotted lines, they have a much better outcome compared to non-responders. So these are data from the UPSTEP trial, which was a negative study, in fact, but in this trial, patients who actually responded to the guided therapy approach actually had better outcomes. So trying your best to induce that responsive phenotype is very, very important. Time and response, the concept of getting a patient there and keeping them there. These are patients in the third tertile of time and response. What we did in PROTECT was we integrated the amount of time over the 10 months of follow-up that a patient spent below the goal value of 1,000. Those patients who spent the most time below 1,000 had the lowest event rates. Patients that intermittently rose above and fell below and rose above had intermediate outcomes. And those patients that never really reached the goal had the worst outcomes. So it really speaks to this desire to try to get patients as low as you can get them and keep them there for as long as possible. And of course, as clinicians, we have to remember that biomarkers are nothing more than a diagnostic and prognostic tool that tells you about a patient's overall risk picture, but does not necessarily, nor should it, replace clinical judgment in terms of your therapeutic decision making. So, if you have a patient who clearly is maximized medically and their BNP or NT-proBNP value continues to be markedly elevated, you're not going to continue up titrating their therapies at the risk of causing azotemia, hypotension, hyperkalemia. It tells you, however, that patient is at risk and that you're going to have to think about what you're going to do next. What's the next step, whether it's those mechanical support options, et cetera, that I mentioned earlier. So to summarize things, ladies and gentlemen, if heart failure therapy, whether guided or not, is associated with substantial lowering of natriuretic peptides, you expect these patients to do better. So serial measurements inform incremental information about prognosis. Falling values are better than rising values, and lower concentrations are better than higher. In chronic heart failure therapy, if you have a goal of excellent care plus reduction of natriuretic peptide concentrations, this leads to intensification of beneficial therapies and is well tolerated with substantial improvements in outcomes and quality of life in certain trials. When appropriately employed, this concept of guided therapy appears to be superior to standard of care. So people have said, are we there yet? Do we have enough data to justify lifting it up to a class 1 in the guidelines and to tell people, at the American College of Cardiology meetings that you should be doing this every day in the office? Well, a lot of people actually do it because the downside is relatively small and the benefit appears relatively clear. But I would argue that what we need now are the large-scale pivotal multi-center trials that lift drugs to the Class 1 indications. And in fact, those trials are about to launch. We've received funding from the NIH to do a large outpatient NT-proBNP trial, and there will also be a home BNP monitoring trial utilizing fingerstick monitoring as well. So there are 2 large prospective pivotal trials planned that should hopefully in the next couple of years answer this question definitively once and for all, that this approach should be part of what we do on an everyday basis for our patients with heart failure. And then ultimately, for those from industry that are in the room as well as from the NIH, acute heart failure is clearly an area ripe for investigation in this area. So I'd like to thank you very much for your attention, and we have a little time for questions. Thanks.
Thank you, Dr. Januzzi. Yes, I think we may have time for, unfortunately, maybe just one quick question for the doctor, and then would you be available to take
Sure.
a few offline? Any questions for Dr. Januzzi? I can't believe that.
I think
Well,
Major Watts sitting in the back actually
was
has
there
a
did
question.
I see a hand?
BNPs all the time. It's an important supplement to what we do, and I think that certainly
Not on.
also parsing out the different subgroups of heart failure, whether they're preserved ejection fraction or reduced ejection fraction, and then the cutoffs, because right now we're using BNP as a one-fits-all.
Right.
It's not a one-fit-all sort of thing.
I agree, Jim, that, for example, with heart failure preserved EF, this is a thorny subject both from a therapeutic side, but also are they the same biochemically as well? And I think that, these are things that need to be looked at more closely. I can tell you that in larger studies, the prognostic threshold for BNP or NT-pro seems to be about the same for HFpEF, but they're different diseases, so we shouldn't necessarily lump them together. We will be, in the home BNP monitoring trial, be looking at HFpEF as well as heart failure with reduced EF, going into it with the clear recognition that HFpEF is a group of patients that are challenging on multiple levels. And so, making a pre-specified subgroup of HFpEF is crucially important so we don't torpedo the whole study as a whole, just based on the HFpEF patients.